lecture has been taken last, but ideally it is the first part we started. So esophagus, we should have started with oral cavity. So now today's lecture we will be talking about the oral cavity and salivary gland pathology. Again, thanks to Dr. Prasad, from whom I am borrowing slides from the internet. So we will be talking of some infections that are happening in the oral cavity, as well as the most number one killer disease and the most dreaded thing to happen is squamous cell carcinoma of oral cavity. So we will be first dealing with what infections can occur, what ulcers, what pre-malignant conditions can occur in the oral cavity, and later on we will talk the malignancies that can happen, and then move on to squamous cell carcinoma. So the first thing that can happen is an herpes simplex virus infection. So when we talk of this herpes simplex viral infection, it is basically a infection caused by the simplex virus 1, HSV1. Very rarely HSV2 causes the infection, and it mostly affects the gingiva and the stoma. So the condition that happens is called as acute herpetic gingivostomatitis. It starts with an abrupt onset. Patient presents with a lot of vesicles and ulcerations in the mouth, and it may be accompanied by the cervical lymphadenopathy, fever, anorexia, and irritability. So when we look at the lesions, of the herpes, what we get vesicles which are filled with clear serous fluid. These vesicles may ulcerate, and once they ulcerate, they form a red rimmed shallow ulcers, very typical of an herpetic ulcer, a red rimmed shallow ulcer. And the microscopic preparation of this herpetic ulcer, this preparation is called as an Zank preparation. The T is silent, Zank preparation, and under this we get very beautiful intranuclear viral inclusions, and you may get multinucleate polycarons. These herpetic infections, they clear on their own within 3 to 4 weeks, and many times they are lying dormant in the local ganglia, that is the trigeminal ganglia. In some individuals whose immunity is low or weak, they may be reactivated to produce a mild cold sores. So what are the things that may predispose to activation of this virus again? So these things, like if you are exposed to ultraviolet light, one has upper respiratory tract infection, pregnancy, menstruation, immunosuppression, exposure to extreme temperature, suddenly this virus is reactivated. Otherwise it is lying dormant in the local ganglia. And this is very nice picture to show you the intranuclear. You can see by the arrows, so this is the nucleus and this is the intranuclear inclusion. So it is said that in herpes we see 3 M's: molding of the nuclei, margination of the chromatin, and multinucleation. So very easy to remember: molding, margination of chromatin, and multinucleation. So these are the 3 nuclear changes which you see in a herpes. Please remember this. So you can have this repeated herpetic stomatitis where you get small group of vesicles, usually on the lips, nasal orifices, buccal mucosa, gingiva, and hard palates. They heal on their own within a week to 10 days. So this is a nice illustration showing you an herpetic infection. The most common infection in the mouth is oral candidiasis. Now when we talk of oral candidiasis, this is also clinically called as thrush. So this candidiasis, basically this infection depends on three factors. Most important factor for causation of oral candidiasis is the immune status of the individual, the strain of the Candida albicans that is present, and the composition of an individual's oral flora. This infection presents in the three major clinical forms. One where we get pseudomembranes, that is called as thrush, very commonly called as thrush, a white lesion. Second would be erythematous type of presentation and hyperplastic type of presentation. It is very common, as I told you earlier, in patients with immunosuppression. So whenever you see a patient of oral candidiasis, one must ask the history of taking some immunosuppression drugs, diseases like diabetes mellitus, transplant has been done or not, there is neutropenia, some sort of chemotherapy whether the patient is taking, or history of HIV infection, and consumption of broad spectrum antibiotics. This is a very important history, and once you see this picture, I don't think so you will forget this picture. So this is a very classical example of oral thrush in a child here. You can see on the mucous membrane, on the tongue, beautiful pictures of oral candidiasis or thrush. Now when we talk of deep fungal infections, a lot of fungus can happen. Just this, you can just remember this list: histoplasma, blastomycosis, coccidomycosis, cryptococcus, zygomycosis. So in infections, as undergraduate students, when we talk of infections of the oral cavity, two major things you have to remember: the herpes infection and the candida infection. So these are the two major, most important things when we talk of oral cavity. Now moving on to the next part that can happen in the oral cavity, that is precancerous lesions. Again, we have to remember these three. Out of that, number 1 and number 2 are very important. It is leukoplakia and erythroplakia. And there is third, precancerous lesions, that is submucus fibrosis. Please remember, all these three are precancerous. And these are again very beautiful pictures showing you these white lesions which cannot be scraped off. So that is the difference between a thrush and a leukoplakia. Candidiasis, you can scrape it off, as compared to this lesion of leukoplakia, where it will be very difficult for you to scrub off the lesion. Leuko is white in color, erythroplakia is red in color. In between two, erythroplakia has a more malignant potential as compared to leukoplakia for conversion into malignancy. And this is submucous fibrosis. So this is the major problem, major problem now we are facing in India. Hundreds and thousands of patients are having this, lakhs of patients I would say, having this lesion of submucous fibrosis, where they cannot open their mouth because of this fibrosis, and tobacco and gutka are the major factors that cause this type of lesions. Major culprit here is the gutka eating habit. Please try to avoid this, as far as in all the people you see, as well as in yourself. And if these habits are not taken off, what you will end up in these kind of pictures. All sorts of lesions here, you can very well see what has happened here. This is, anyone can tell that this is cancer. And this is exactly what it is. It is squamous cell carcinoma of oral cavity, the number 1 killer disease in India, the number 1 cancer in India right now, that is squamous cell carcinoma. So this carcinoma is the most aggressive epithelial type of malignancy, as far as the rankings, these are actually bad rankings, but rankings, when we talk of rankings in the world, this is the 6th most common neoplasm in the world today. As far as India is concerned, it is very, very common in our country. And despite the various advances in the treatment, the long-term survival, the chances of patient to survive is very less. It is less than 50%. For a very long time, this figure is not going up. So, luckily, there is a hope here that if the cancer is detected at an early stage, please remember this, because this is preventable, this can happen. If a cancer, oral cancer is detected at an earlier stage, the early stage 5-year survival rate are almost 80%. They're almost 80%, 80. But if the same patient comes and reports in a late stage of disease, the survival very drastically drops down to 18%. And that is why early detection of these pre-malignant lesion is very, very critical. We just talk of theory, but when it comes to practice, we are very practice-oriented people. We should be focusing on the early detection of these pre-malignant lesions. As far as this oral cavity is concerned, lesions like leukoplakia, erythroplakia, submucus fibrosis, wherever you can intervene, please try to educate the patients regarding the use of tobacco, alcoholism. And the third important factor now, these squamous cell carcinomas are associated with the HPV virus, especially the 6, 16 and 18. Earlier there was implication of causation of these viruses in the cervix, but now people have come up with the studies, mostly Western studies, not in Indian studies, the presence of HPV types in 6, 16 and 18 in cases of oral squamous cell carcinoma. And radiation is also one of the factors that can cause. So you have to remember 3: tobacco, alcoholism and HPV as the main etiological factors of oral cancer. They can be also talked of 8S. So for example, in syphilis, sharp tooth, spices, smoking, tobacco, sunlight, actinic damage and betel nut chewing. So this is the etiology of squamous cell carcinoma we can remember. So when we talk of HPV or genetic related problems regarding the molecular progression, so as with the other cancers also, this has got a whole range. It goes through normal mucosa being irritated by some irritant, maybe anything, converts itself into hyperplasia or hyperkeratosis, some genetic alteration plus the irritation goes on, develops a mild, moderate dysplasia, severe dysplasia, and later on squamous cell carcinoma. Please remember, this is an ideal sequence. The disease may not progress in the similar fashion. Mostly it is the tongue and the areas surrounding the tongue that is the site for the oral cancer. So base of the tongue is the most important site. The sulci are the second important things, tip of the tongue, and then the pharynx or the upper part can be affected. The roof of the oral cavity can be affected by the squamous cell carcinoma. Very scary pictures. This is one separate variety of oral squamous cell carcinoma which is called as an verrucous carcinoma. Very, very scary pictures. Microscopically it's very typical. You get 3 types, you can say classify them into well differentiated, moderately differentiated, poorly differentiated squamous cell carcinoma, where you can see islands of squamous cells, hyperchromatic pleomorphic nuclei, and they form squamous pearls. So that is a very classical picture of squamous cell carcinoma. Everywhere or anywhere in the body, it is the same malignant islands of squamous epithelium. Pearls are seen in the or individual cell keratinization seen in the well differentiated or moderately differentiated. In poorly differentiated, it becomes very difficult to identify this feature. Metastasis, usually they go to the lung, liver and bones, and most commonly initially they go to the local, we can say that, regional nodes of the head and neck. So with these we have come to the end of the lesions of the oral cavity. I'll revise again: some viral infection like herpes, candidiasis, precancerous lesions, and the lesions of the most, as I said, the dreaded lesion in the oral cavity is squamous cell carcinoma, also called as epidermoid carcinoma. And the etiological factors for this: tobacco chewing, alcoholism, and HPV virus are very, very important for this. So with this, now we move on to just an area which is near, and that is salivary gland. So we will just see the pathology of the salivary glands. So when we talk of salivary glands, again for you to remember is, as is the pattern in everywhere in the systemic pathology, there will be infectious etiology and there will be neoplastic etiology or malignancies. So in salivary gland, as undergraduate students, we have to remember mainly 4 or 5 tumors. Out of that, 2 benign and 3 malignant. That is how we tell the undergraduate students. And then just going into that, before that, we just have what are the basic elements of the salivary gland unit, so that it becomes easier for you to understand which tumors take origin from which. And this salivary gland is said to be a very, it is said to be nightmare for pathologists, because variety of structures are present and variety of neoplasm and combinations of malignancies can happen there. So the most important thing that happens there is called as Pleomorphic Adenoma, and you can see that it originates from the intercalated duct that is present here. Okay, so this is an intercalated duct, and this is the site of origin for most of the benign tumors that are called as pleomorphic adenomas. And also it can originate from the cell lining. This is called as the myoepithelial cell. This whole unit is called as acini. Acini opens into intercalated duct, striated duct, and later on excretory duct. So ducts and acini are the basic structural unit of a salivary gland. When we talk of certain oncocytic tumors, they take origin from the striated ducts. Acinous cell tumors, they originate from the acinar cells here. The origin of acinic cell carcinoma or acinous cell tumor is here. And then when we talk of a term called as Mucoepidermoid tumor and squamous cell carcinoma, they develop into this excretory duct. There are exclusive tumors also originating from the myoepithelial cells. So these system for classification, staging system is very important when we talk of a salivary gland cancer, because the prognosis depends on this. How far the tumor has gone, whether it is limited to the primary site, what is the size of the tumor, that is very important for prognosis of salivary gland cancer. So this is normal histology. We have already discussed this, acini and ducts. So the first important tumor when we talk of salivary gland that you should be remembering is pleomorphic adenoma. So it is said to contain both epithelial cells and stromal component. I'll show you some more pictures. We just first go through what it is composed of. So the epithelial component is composed, or it can show variety of arrangement, tubular and cord-like arrangement. The epithelial component cells, they contain a moderate amount of cytoplasm, and very rarely they can show mitosis. Whereas the stromal component, or which is called as a mesenchymal component, and this is where it is very important to remember, this component can be very variable, and this can be attributed to the myoepithelial cells I just showed you. Most of the tumors of pleomorphic adenoma, they show chondroid or cartilaginous differentiation. Very rarely it happens that these tumors may convert themselves into malignancy, and when that occurs we call them as carcinoma X pleomorphic adenoma. But by and large, this tumor, when we classify it, is said to be a benign tumor of salivary glands. Osseous metaplasia is also quite common in this, and you get hypocellular areas composed of pale blue to eosinophilic tissue. The peculiar part of this pleomorphic adenoma is the diverse microscopic pattern. What I mean by this is, in this you can get cuboidal-like cells arranged in duct-like structures. You get a very loose chondromyxoid stroma. You can appreciate that here. Hyalized connective tissue, and even sometimes you will get osseous tissue. This pleomorphic adenoma is very typically encapsulated, and you may get some tumor cells around the fibrous capsule, but mostly it is an encapsulated. You can appreciate this cartilaginous stroma. So stroma is very peculiar in this tumor as against the epithelial cells. So this was pleomorphic adenoma, a benign tumor of salivary gland. I'll show you a few more presentations so that the concepts become clear. The second most important tumor you should remember in salivary gland is Warthin's tumor. As undergraduate students, this is very important tumor, Warthin's tumor. This is also called as a benign papillary cyst adenoma lymphomatosum. And if you remember this name, it becomes very easy to understand the microscopy. So first, it is a benign tumor. Second, it has papillary in nature. Cyst, it has got various cystic spaces, and there is a stroma composing of mainly lymphoid tissue. So it is called as papillary cyst adenoma lymphomatosum or Warthin's tumor. Now this tumor is the second most common benign tumor of the parotid gland after pleomorphic adenoma. It almost accounts for 2 to 10% of all parotid gland tumors. In only 10% of the cases it may be bilateral, 90% of the cases it is unilateral. And as it is cystic in nature, if we do an FNAC, we may get a mucoid brown fluid when we do an FNAC of this tumor. So if you see this in the mid power, it is, some people say it is arising from the salivary gland inclusions within the lymph node, and it has got an epithelial component which comprises of papillary fronds, and very typically these fronds, they demonstrate 2 layers of oncocytic epithelial cells. These words you should be very clear. So papillary fronds showing two layers of oncocytic epithelial cells. The cytoplasm stains deep pink and shows granularity. This granularity is attributed to the abundance of mitochondria that is present in these tumors, these cells. and very occasionally it undergoes squamous metaplasia. So one has to be very careful, should not call it as squamous cell carcinoma on FNAC. Very important thing to remember. And then there is a epithelial component comprising of this oncocytic type of epithelium, cysts, and then second is the lymphoid component, which is very in abundance. You will get lymphoid follicles, lot of lymphoid follicles, occasional germinal centers will be seen, and this lymphoid tissue forms the core of the papillary structure. So to diagnose Wardens, please remember you should have oncocytic epithelial elements as well as the lymphoid component present. So two tumors we have seen, pleomorphic adenoma. Again, a lot of variety is seen in the epithelial elements and in the stromal component, chondromyxoid type of stroma showing hyalinized connective tissue, and epithelial component showing tubules and all sorts of things. When we come to Wardens, again benign tumor, benign papillary cyst adenoma, lymphomatosum. What is the epithelial component? Epithelial component is a bilayered oncocytic type of epithelium with granularity. Cysts are present, and then mostly you will get large lymphoid component composing of occasional germinal cells, and they form the core of the papillary structure. So for the diagnosis, so you can see on this picture, very beautiful picture, you can appreciate this bilayer of oncocytic type of epithelium, and these are the lymphoid infiltrates. So bilayer of epithelium and lymphoid infiltration is a classical on Warden. And when we see on the scanner view, you can appreciate this is papilla, some form of cyst. So papillary cyst adenoma, lymphomatosum. You can appreciate on this power the bilayers also oncocytic epithelium. And what is the hallmark of this? If you see, a lot of mitochondria, abundance, tremendous number of mitochondria which are responsible for this oncocytic change. That is, what is oncocytic change? How does it look like? It is a granular eosinophilic appearance. Granular eosinophilic appearance, where the mitochondria rich oncocytes are found in the tumors. Just as students, you should know, as there is pleomorphic adenoma, there is also monomorphic adenoma in salivary gland, which is again a benign tumor. Whereas when we talk of pleomorphic adenoma, there was a lot of mesenchymal stromal component. Here it is mostly monomorphic adenoma composing only of the epithelial component, as against the pleomorphic adenoma, which is seen in the parotid gland. These monomorphic adenomas are common in the minor salivary glands, especially the upper lips. 12% of these tumors are bilateral, and rarely they can have a malignant potential. There are different histological types, but you should just, you can know them: basal cell, cannular, myoepithelial, clear cell adenoma, membranous adenoma, and all these adenomas, they have got their typical histology. Just remember, there is a pleomorphic adenoma, there is a monomorphic adenoma. So two benign tumors, pleomorphic adenoma and Wardens, and now three malignant tumors in salivary gland, which you should remember. And the first and most important out of these is Mucoepidermoid Carcinoma. Again, the name is also giving you a hint what components it will have. It will have mucin producing cells and epithelial cells of epidermoid variety, means looking like squamous type of cells. So it has got an epidermoid component and a mucinous component. So classically it is said to be three types of things are to be present when we diagnose a mucoepidermoid carcinoma. Very typically this is classified into a low grade type or well differentiated, and high grade, which is also called as a poorly differentiated Mucoepidermoid Carcinoma. So it is the most common malignant tumor of the parotid gland. Please remember this very important statement. It is the most common malignant tumor of the parotid gland and the second most malignancy of the submandibular and minor salivary glands. When we talk of, as we all know, salivary glands we classify them into major salivary and minor salivary. So when we talk of major salivary glands, mucoepidermoid is the most common malignancy, and when we talk of minor salivary glands, it is second. And the number one here is taken up by the adenoid cystic carcinoma. So you can stain this mucoepidermoid carcinoma by mucicarmine, and when we talk of statistics, it constitutes approximately 35% of the salivary gland malignancies, and most of these they occur into the parotid gland. I'll again show you some more presentations in picture just to make you aware of this sequence. Then the second most malignant tumor is adenoid cystic carcinoma, and the feature of this, so the feature of mucoepidermoid is mucus and epithelial cells. When we talk of adenoid cystic carcinoma, you can very well appreciate it. This is called as a Swiss cheese pattern. You see these like punched out holes. They are said to be punched out holes like a Swiss cheese. So it is second most common malignant tumor of the salivary gland, major salivary gland, and when we talk of the minor salivary gland, it is the first most common tumor in the submandibular, sublingual and other minor salivary glands. The speciality of this adenoid cystic carcinoma, it has got a tendency to go and invade the nerves. So that is the point. You should very well remember that nerve invasion is a very important feature of an adenoid cystic carcinoma. You can see that this is the nerve and this is the area. I hope you appreciate it. This is the nerve and this is the tumor cells, adenoid cystic carcinoma. And the spread may occur by the emboli along the nerve lymphatics. And this is the look I was talking about. So this is the Swiss cheese pattern, punched out holes. That is the feature of an adenoid cystic carcinoma. The third tumor you ought to know, third malignant tumor, is acinic cell carcinoma. As you all know, the acini, it arises from the acini of the salivary glands, and it commonly occurs in the parotid gland. Also it is called as a blue dot tumor. Again it is multicystic pattern, and past tense the cells are very heavily stained. The look here, again the feature of this tumor is that the cells may look very benign, but they have got a malignant behavior, and these lesions mostly are treated by the surgical excision. When we talk of tumors, lymphomas, just a word to mention, lymphomas also can occur. Hodgkin disease is quite common in the parotid gland. So when we talk of the features which are suggestive of malignancy clinically, we will find that these tumors are indurated, they are fixed to the overlying skin or mucosa, ulceration is there, growth is rapid. Patient will come to you with a very history of rapid swelling, short duration, and the pain, which is very severe, may be because of involvement of the nerve and can come with facial palsy. So I will try to show you one more presentation. Again download it from the net. By the aim of this showing you different kind of pictures is that you remember it visually very well. So three major salivary gland, the parotid gland, the submandibular gland and sublingual gland, and the rest are minor salivary glands located into the mucosa and the oral cavity. The function of these glands is to produce saliva, which is important for protection, lubrication, buffer, digestion, taste. So this is normal histology of the acini and the ducts. The acinar cells can be classified into serous cells, which produce a very thin watery secretion, and mucous cells, which produce a more viscous type of secretion. So when we talk of a salivary gland secretory unit, mainly it is composed of terminal acini. You can see there. This is a serous cell secreting serous fluid. This is a mucous cell which will secrete mucus, intercalated, striated and excretory ducts, and then there are myoepithelial cells. So parotid is comprising of serous secretion, the submandibular is responsible for mucus and serous, and sublingual is totally mucus secretion. So diseases, as usual, they can be neoplastic, developmental, infectious, inflammatory, autoimmune and ischemic. So we'll just go to the tumors directly. The etiologic factors for a salivary gland tumor to occur can be a patient may be exposed to radiation, he may have some genetic predisposition, habit of tobacco chewing, exposed to chemical carcinogens and viruses. So when we see the incidence, mostly they comprise of the 6% of the head and neck neoplasms, usually occur in the 6th to 7th decade. So you can just remember, occurring in very old age. Females are slightly more affected as compared to the male, and very easy to remember, most of the pathologies or most of the tumor occur in the parotid gland. So very easy for us you to remember. Parotid gland takes up the brunt of almost 80% of the tumors. They occur, rest in the minor salivary glands of the palate, and then followed by the submandibular gland. Very few tumors they occur in the sublingual salivary gland. When we talk of tumors, we have already seen that if the tumors arise in the gland, they may arise from the epithelial part, which is called as parenchyma, or they may arise from the supportive stroma, and there are mixture of them, so mesenchymal part. So when we talk of these benign parenchymal tumors that is arising from the salivary epithelium, they will be talked as adenomas, and when malignancy occurs in these epithelial cells, we talk it as adenocarcinomas. Then it may occur from the basal cells, ductal cells, striated cells, ducts, acini and things. By and large, we have seen this. Tumors are classified as benign and malignant. Benign tumors, two things you have to remember: Pleomorphic Adenoma and Wardens. In malignant, 3: Mucoepidermoid Carcinoma, Adenoid Cystic Carcinoma and acinic cell carcinoma. So this is the list for tumors. As I told you, 5 tumors as UG students you should be remembering. So as with all the benign tumors, the general characteristics of salivary gland tumors are also, they grow slowly, mostly they are asymptomatic, do not fluctuate in the size. This pleomorphic adenoma can convert into malignancy, or malignant transformation can occur, and when it occurs it is called as an carcinoma ex pleomorphic adenoma. The second benign tumor we had seen, Wardens tumor, the name again I will revise: papillary cyst adenoma lymphomatosum. Here males are more affected as compared to females. Occurrence age is 5th to 7th decade, 30 to 50 was pleomorphic. This is a more older population, 50 to 70 years. Painless mass, site again parotid, can be multifocal, and somehow this Wardens has got an 8-fold risk of occurring in cases of smokers. Grossly cystic mass, well circumscribed cystic mass, there will be papillations, and you can get this machine oil type of secretions. Histologically, you will get papillary fronts. I have already told you bilateral oncocytic cells and lymphoid stroma. Bilayer, you can see these layers of oncocytic epithelial cells, and these epithelial cells are on the lymphoid stroma. Treatment of this is surgical excision. You can take out the parotid. Prognosis is excellent. Again, same complication, there can be recurrence, association with other salivary tumors. Malignant transformation is quite rare. I will not go into the other benign tumors. Oncocytoma is there, papillomas, papilliform adenomas, monomorphic adenomas, different types of them, basal cell, canalicular. Will not go into the details, directly move on to the malignant epithelial tumors, and out of that, most importantly, is Mucoepidermoid Carcinoma. Other things can occur, adenocarcinoma, otherwise specified, acinic cell, polymorphous, adenoid cystic. For you to remember, mucoepidermoid, adenoid cystic, and acinic cell carcinomas. So, as is with the other tumors, they have got a malignant tumors, they have got a shorter duration than benign tumors. They grow rapidly. They have a history of slow growth with sudden rapid activity. They can be fixed to the surrounding tissues. Overlying skin may be ulcerated or inflamed, and they can show surface telangiectasia. Usually, when it is in the malignancy and that is into parotid gland, they are associated with facial nerve paralysis. Regional lymph nodes may be enlarged. Palate and retromolar gland tumors infiltrate the bone, radiolysis, and loosening of teeth. Salivary gland tumor staging, I have already shown you, important whether they are limited to the gland or not. So, most important tumor, mucoepidermoid, which is the second most common salivary gland tumor, ages from 2nd to 7th decade, slightly female predilection, mostly occurring into the parotid related with radiation, this thing. Grossly well circumscribed to encapsulated or uncapsulated. Histology, you will see mucus cells, you can appreciate them. These are the mucus cells. You can see the epithelial cells and then intermediate cells. So, low grade and high grade. So, low grade will be, mucus cells will be more than epidermoid cells, or they may be equal in proportion, very small number of cysts and increased pleomorphism and mitotic figures. And when we talk of an high grade mucoepidermoid carcinoma, where the epidermoid cells are more as compared to the mucus cells, mostly solid. And very important thing to remember, this mucoepidermoid, because of the predominance of these epidermoid cells, can be mistaken for a squamous cell carcinoma. So you have to do a mucin staining, and then the mucus will stain. There are different gradings, you go into the detail. The treatment is mainly influenced by the site, the stage, and the grade. So if it is stage 1 and stage 2, wide local excision, and if it is stage 3 and stage 4, radical excision and neck dissection. The prognosis is that this tumor has a tendency to recur. Metastasizes to lymph nodes, lung, bone, skin. Low to intermediate grade, the prognosis is good. High grade, the prognosis is poor. Second is acinic cell carcinoma. Again, second most common parotid and pediatric malignancy, seen in the 5th decade, can be bilateral well demarcated. Histopathology, you will see circumscribed variable growth patterns. Most common is solid and microcystic. You can see this SNL cells there with small dark eccentric nuclei and a basophilic granular cytoplasm. Treatment is surgical excision. If it is low grade, there is chance of recurrence. It is high grade, then the prognosis is bad. And the last category is adenoid cystic carcinoma. Overall, it is second most common malignancy, common in the submandibular, sublingual, minor salivary gland. Males are equally affected as compared to females. Occurs in the 5th decade. Highly infiltrative. Please remember Swiss cheese pattern and perineural invasion are the hallmarks of this tumor. This is very classical, nice cribriform pattern it is called as, or Swiss cheese pattern, and in a microscopy you will get layered form, duct-like structure, mucinous substance, solid nest of cells without cystic or tubular spaces. Complete local excision is the treatment. Has a tendency for facial nerve invasion, so we have to sacrifice the facial nerve. Post-operative radiation has to be given. I will not go into the details of the other tumors. 5 tumors are important for you to remember when we talk of the salivary gland tumor. So with this now we have completed the whole of the gastrointestinal tract. We talked about lesions of the oral cavity. In the oral cavity, we discussed viral lesions in the form of an herpes, simplex lesions. We talked of oral candidiasis. We talked of the tumor. We talked of precancerous lesions, mainly leukoplakia, erythroplakia, and submucous fibrosis. We talked of squamous cell carcinoma, number 1 killer disease in India, associated with smoking, alcoholism, and viral etiology. Then from oral cavity we moved on to the esophagus. In esophagus we talked of different kinds of infections. Esophagitis, we talked of GERD, that is gastroesophageal reflux disease. We talked of Barrett's esophagus, that is very most important condition to remember. And we talked of squamous cell carcinoma of esophagus, comprising of the upper portion, and in the lower part adenocarcinoma of the esophagus. Then we move on to the stomach. In stomach we discussed different kinds of ulcers, stress ulcers. Then we talked about in detail about the peptic ulcer disease, and in stomach we talked about different tumors that can occur, and most importantly gastric carcinoma. Adenocarcinoma is the most important thing that can occur there. In that, the words like signet zinc carcinoma, leather bottle appearance of the stomach, and areas, different locations of gastric carcinoma is important. We moved further down. We talked of 2 important lesions in the small and large intestine, ulcerative lesions, ulcerative colitis and Crohn's disease. We talked about the difference. We talked about their etiology, mostly immune in nature. We talked about the gross differences of the ulcers. We talked how microscopically they differ. For example, Crohn's disease, which is a transmural type of inflammation associated with granulomas and type of rigidity, hose pipe type of rigidity, and things like that. And also we mentioned about other ulcers that occur there in the form of tuberculous ulcer and typhoid ulcers. Mostly these will be covered in your practicals. And then we talked about yesterday of the carcinoma of colon and rectum, where important for you to differentiate between the left-sided tumors and the right-sided tumors. We talked how the tumors differ clinically. Histologically it is mostly adenocarcinoma, but the clinical presentation like obstructive and exophytic growth, napkin ring type of constriction, and change in the bowel habits, and one presents with the obstructive element. So that was the overall overview of the gastrointestinal tract system. Very important things, short notes mostly related to the salivary glands. All these 5 tumors can come as short notes. In the esophagus, Barrett's esophagus can come as a short note. If malignancy came as a long question. In GIT, peptic ulcer disease can become a long question. Malignancies are long questions. Ulcerative colitis, it is inflammatory bowel disease as a long question. So as from the exam point view also, GI tract is important. Colorectal carcinoma comes also as a long question. So with this we have completed the series on the gastrointestinal tract pathology. Thank you.